Okay, so this recording is for the 31st day of the Final Frontier Npte prep course, March 9th, 2020, Monday. Therapeutic exercise, strength, endurance, mobility training from the Therapy Ed 2018 edition, Chapter 9. This is going to be an easy one. We as PTAs probably should know most of this stuff. Okay, strength training, concepts of muscle function and strength. Strength is the force output of a contracting muscle and is directly related to the amount of tension a contracting muscle can produce. Contractile elements of muscle. Muscles are composed of fibers, which are made up of myofibrils. Myofibrils are composed of sarcomeres that are connected in series. The overlapping cross bridges of actin and myosin make up a sarcomere. When a muscle contracts, the actin-myosin filaments slide together and the muscle shortens. The cross bridges slide apart when the muscle relaxes and returns to its muscle length. Motor unit nerve supply to the muscle. 3 different types of fibers, pretty sure. Motor unit nerve supply to the muscle. Slow twitch fibers, type 1, are slow contraction speed, low force tension production, highly resistant to fatigue. So slow twitch, slow contraction speed, highly resistant to fatigue. Fast twitch, type 2A. Fast contraction speed, fatigue resistant. Characteristics can be influenced by the type of training. Fast twitch fibers 2B, type 2B. Fast contraction speed, high force production, and susceptible to quick fatigue. So that's type 2B. Hereditary influences in fiber type distribution. The percentage of either fast twitch or slow twitch fibers in the body is determined by genetics. This ratio cannot be changed via normal exercise. Specific training can modify metabolic characteristics of all fiber types. High intensity anaerobic training strengthening will stimulate optimal fast twitch adaptation. Order of fiber type recruitment. Recruitment order depends upon the type of activity, force required, movement pattern, and position of the body. Slow twitch motor units have the lowest functional thresholds and are recruited during lighter, slower efforts such as low intensity, long duration endurance activities. Higher forces with greater velocity cause the activation of more powerful, higher threshold, fast twitch motor units. Order of recruitment is slow twitch, followed by fast twitch type 2A, and finally followed by fast twitch type 2B motor units. Length tension. As the muscle shortens and lengthens through the available range of motion, the tension it produces varies. Maximal tension is generated at some midpoint in the range of motion. Less tension is developed in either shortened or lengthened range of motion. The weight lifted or lowered cannot exceed that which the muscle is able to control at its weakest point in the range of motion. When a muscle is stretched beyond the resting length, there is a mechanical disruption of the cross bridges as the microfilaments slide apart and the sacromeres lengthen. Releasing the stretch allows the sacromeres to return to their resting length. This change in ratio of length to tension is called elasticity. Once released, the muscle stretched into the elastic range can contract and produce a force or tension as the muscle returns to its original length. Adaptations to strength training. Muscle. Hypertrophy is an increase in muscle size as a result of resistance training and can be observed after at least 6 to 8 weeks of training. Remodeling. Individual muscle fibers are enlarged, contain more actin and myosin, and have more larger myofibrils. Sarcomeres are increased. An increase in motor unit recruitment and synchronization of firing facilitates contraction and maximizes force production. The average person has a ratio of 50% fast to slow twitch motor units. Performing workloads of low intensity will challenge half of the body's muscle mass. High intensity exercises for shorter durations, less than 20 reps, are needed to train the highly adaptable fast twitch type 2A fibers. Disuse atrophy occurs when the muscle loses both size and strength from lack of use or when the limb is immobilized. Cross-section area of a muscle highly correlates with strength gains. The larger the muscle, the greater the strength of that muscle. Positive changes in impairments. Improvement in strength, bone mass, body composition, fat to lean body composition, weight control and weight maintenance, decreased risk of adult onset diabetes, reaction time, metabolism, calorie burning during and after exercise, cardiovascular status, reduction in resting blood pressure, immunological function, positive changes in function and quality of life, improved balance and coordination, gait and functional mobility, activities of daily living, job, recreational, athletic performance, sense of well-being, posture, and self-image. Guidelines to develop strength. Overload principle. To increase strength, the muscle must be overloaded or challenged beyond its current force capability. Higher levels of tension will cause hypertrophy and recruitment of muscle fibers. This level will change with each adaptation. Specificity of training. Adaptations in the metabolic and physiological systems of the body depending on the type of overload imposed. Specific modes of exercise elicit specific adaptations, creating specific training effects. Reversibility. Benefits of training are not sustained unless muscles are continuously challenged. Detraining effects include decreased muscle recruitment and muscle fiber atrophy. Metabolic effects of training. Muscle contraction to about 60% of its force generation capacity causes a blockage of blood flow to the working muscle due to increased intramuscular pressure. The energy source for this level of muscle contraction is mainly anaerobic and does not improve with aerobic conditioning. Strength training of specific muscles has a brief activation period and uses a relatively small muscle mass, producing less cardiovascular metabolic demands than vigorous exercise such as walking, running, and swimming. Rhythmic activities increase blood flow to exercising muscles via a contraction and relaxation milking action. The primary energy source is aerobic. Circuit training, cross training, with high repetitions and low weights, incorporates all modes of training and provides more general conditioning to improve body composition, muscular strength, and some cardiovascular fitness. E. Common errors associated with resistance and strength training. Valsalva maneuver. Valsalva maneuver. Forcible exhalation with the glottis, nose, and mouth closed while contraction is being held. Valsalva maneuver increases intrathoracic pressure, slows heart rate, decreases return of blood to the heart, and increases venous pressure and cardiac work. Inadequate rest after vigorous exercise. 3 to 4 minutes is needed to return the muscle to 90 to 95% of pre-exercise capacity. Most rapid recovery occurs in the first minute. Increasing exercise progression too quickly. Intensity, duration, and frequency can overwork muscles and cause injuries. Substitute motions occur from too much resistance, incorrect stabilization, and when muscles are weak from fatigue, paralysis, or pain. Exercises to improve strength and range. Manual resistance, a type of active exercise in which another person provides resistance. Advantages. Useful in the early stages of an exercise program when the muscle is weak. The therapist can judge the capability of muscle to safely meet demands of exercise. Can be modified for a painful arc in the joint range of motion. Safe resistance exercise when the joint movements need to be carefully controlled and the resistance is mild to moderate. Can be easily changed to include diagonal or functional patterns of movement. For example, proprioceptive neuromuscular facilitation, PNF, or appropriate facilitation techniques such as a quick stretch. Disadvantages. The amount of resistance cannot be measured quantitatively. It may be difficult to maintain the same resistance during the full range of motion and to consistently repeat the same resistance. The amount of resistance is limited by the strength of the therapist or caregiver. B. Mechanical resistance, a type of active exercise in which resistance is applied through the use of equipment or mechanical apparatus. Advantages. The amount of resistance can be measured quantitatively and increased over time. Can be used when amounts of resistance are greater than the therapist can apply manually. Disadvantages. Not easily modified to exercise in diagonal or functional patterns. May not be safe if resistance needs to be carefully controlled or maintained at low levels. Goals and indications for resistance exercise. Increase strength in the muscle group that lifts, lowers, or controls heavy loads, for a relatively low number of repetitions. Increase muscular endurance by performing low intensity, repetitive exercise over a prolonged period. Improve muscular performance related to strength and the speed of movement. Precautions. Local muscle fatigue is a normal response of the muscle from repeated dynamic or static contractions over a period of time. Fatigue is due to depleted energy stores, insufficient oxygen, and built up of lactic acid. It is characterized by a decline in peak torque and increased muscle pain with occasional spasm and decreased active range of motion. General muscle fatigue affects the whole body after prolonged activity such as walking or jogging, usually due to low blood sugar, decreased glycogen stores in the muscle and liver, and depletion of potassium. General or specific muscle fatigue may be associated with specific clinical diseases such as MS, cardiac disease, peripheral vascular dysfunction, and pulmonary diseases. These patients fatigue more rapidly and require longer rest periods. Overwork or overtraining causes temporary or permanent loss of strength as a result of exercise. In normal individuals, fatigue causes discomfort, so overtraining and muscle weakness does not usually occur. In patients with lower motor neuron disease who participate in vigorous resistance exercises can have a deterioration of strength. For example, post-polio syndrome, Duchenne muscular dystrophy. Overwork can be avoided with slow progression of the exercise intensity, duration, and progression. Osteoporosis makes the bone unable to withstand normal stresses and highly susceptible to pathological fracture. They develop as a result of prolonged immobilization, bed rest, inability to bear weight on the extremity, and nutritional and hormonal factors. Acute muscle soreness develops during and directly after strenuous anaerobic exercise performed to the point of fatigue. Decreased blood flow and reduced oxygen, ischemia, creates a temporary buildup of lactic acid and potassium. A cool-down period of low-intensity exercise can facilitate the return of the oxygen to the muscle and reduce soreness. Delayed onset muscle soreness can begin 12 to 24 hours after vigorous exercise or muscular overexertion, peaks at 24 to 48 hours after exercise. Muscle tenderness and stiffness can last up to 5 to 7 days. Usually greater after muscle lengthening and eccentric exercise. Severity of soreness can be lessened by gradually increasing the intensity and duration of exercises. Contraindications. 1. Inflammation. Resistance exercises can increase swelling and cause damage to muscles and joints. Pain. Severe joint and muscle pain during exercise or for more than 24 hours after exercise requires elimination or reduction of the exercise. Types of resistant training. Isometric exercise is static and occurs when a muscle contracts without a length change. Resistance is variable and accommodating. Contraction should be held for at least 6 seconds to obtain adaptive changes in the muscle. Repeat. Contraction should be held for at least 6 seconds to obtain adaptive changes in the muscle. Strengthening of muscles is developed at the point in the range of motion, at a point in the range of motion, not over the entire length of the muscle. This type of resistance exercise can increase blood pressure and should be used cautiously with a patient with a cardiac condition. Monitor for potential Valsalva maneuver. Isotonic exercise is dynamic and can be constant free weights or variable machine load. Can have a constant or variable load. As the muscle lengthens or shortens through the available range of motion. Speed can be variable for this type of exercise. Weightlifting machines have an oval-shaped cam and wheel that mimics the length tension curve of a muscle. For example, Nautilus or Cybex. These machines vary resistance as the muscle goes through the range of motion, providing resistance that the muscles can safely complete at various points in the range of motion. Free weights. Free weights do not vary the resistance through the range of motion of a muscle. The weakest point along the length tension curve of each muscle limits the amount of weight lifted. Weightlifting machines are safer than free weights, used early in a resistance exercise or rehabilitation program. Isokinetic exercise. Isokinetic exercise is dynamic and has a speed control for muscle shortening and lengthening. Resistance is accommodating and variable. Peak torque. The maximum force generated through the range of motion is inversely related to angular velocity, speed, as the body segment moves through range of motion. For example, an increasing angular velocity decreases peak torque production. Concentric or eccentric exercise can be performed on isokinetic equipment. Isokinetic exercise provides maximum resistance at all points in the range of motion as the muscle contracts. During isokinetic testing, the weight of the body segment creates a torque output around the knee. For example, the lower leg around the knee joint in sitting knee flexion. This gravity-produced torque adds to the force generated by the muscle when it contracts and gives a higher torque output than is actually created by the muscle. The higher value can affect the testing values of the muscle group and which muscle group needs to be strengthened. Software can correct for the effects of gravity. Okay, I went and got some different pictures. I didn't like that picture. So, pretty cool stuff. Okay, oh yeah. Isokinetic. Eccentric lengthening versus concentric shortening. I don't think we need any pictures for this. Maximum eccentric contraction produces more force than maximal concentric contraction. Resistance training performed concentrically improves concentric muscle strength, and eccentric training improves eccentric muscle strength. Specificity training. Eccentric contractions occur in a wide variety of functional activities, such as lowering the body against gravity, sitting down, or descending stairs. Eccentric contractions provide a source of shock absorption during closed-chain functional activities. Eccentric contractions consume less oxygen and fewer energy stores than concentric contractions against similar loads. G. Range of motion. Short arc exercise. Resistance exercise performed through a limited range of motion. Initial exercise post-knee surgery, such as an anterior cruciate repair. Painful full range of movement. Full arc exercise is resistance exercise performed through full range of motion. Open chain versus closed chain exercises. Open chain exercise occurs when the distal segment, hand or foot, moves freely in space. For example, when an arm lifts or lowers a handheld weight. Resistance exercises usually are open chain, which may be the only option if weight bearing is contraindicated. Open chain exercise does not adequately prepare the patient for functional weight bearing activities. Closed chain exercise occurs when the body moves over a fixed distal segment, for example, stair climbing or squatting activities. Closed chain exercise loads muscles, bones, joints, and non-contractile soft tissues such as ligaments, tendons, and joint capsules. Mechanoreceptors are stimulated by closed chain exercises, adding to joint stability, balance, coordination, and agility in functional weight-bearing postures. Specific exercise regimens. Progressive resistive exercise, PRE, uses the repetition maximum or the greatest amount of weight a muscle can move through the range of motion a specific number of times. Delorme used 10 rep range as baseline. 3 sets of 10 reps are completed with brief rest periods, 1 to 2 minutes between sets. Progression. Exercise begins with 10 reps at 50% of the 1 rep max, followed by 10 repetitions at 75% of the rep max, and finally 10 repetitions at 100% of the rep max. So uses the repetition maximum or the greatest amount of weight a muscle can move through a range of motion a specific number of times. So, if I'm reading this correctly, the repetition maximum, Delorme used a 10 repetition maximum as a baseline. So 3 sets of 10 reps are completed with brief rest periods, 1 to 2 minutes between sets. So the progression is, let's say you can do 10 pounds for 10 reps. Let's say you can do shoulder press 10 pounds for 10 reps, and you can't do any more than 10 reps. So your first set would be 10 reps at 5 pounds. The first rep would be, your first set would be 10 reps at 5 pounds. Your second set would be 10 reps at 7.5 pounds. And then finally, your last set would be 10 reps at 10 pounds. Correct? Yes. So, first set would be 5 pounds times 10 reps. Second set would be 7.5 pounds times 10 reps. And then your third set would be 10 pounds times 10 reps. Yes? Yes. So, your rep maximum is 10 pounds times 10 reps. Right? So your first set would be 5 pounds. At 10 reps. Second set would be 7.5 pounds at 10 reps. And there we go. There's an example. Oops. Transfer some numbers. I always do that, letters. Okay. Yep. Correct? Correct. Correct me if I'm wrong. I don't think I am. Okay, so there you go. Circuit weight training, a sequence of exercises for total body conditioning. A rest period of usually 30 seconds to 1 minute is taken between each exercise. Exercises can be done with free weights or weight training machines. Plyometric training or stretch shortening activity. An isotonic exercise that combines speed, strength, and functional activities, used in later stages of rehabilitation to achieve high level of performance. For example, jumping off a platform, then onto a platform at a rapid pace to improve vertical jumping abilities. Brief, repetitive, isometric exercise occurs with up to 20 maximum contractions held for 5 to 6 seconds and performed daily. A 20-second rest after each contraction is recommended to prevent increases in blood pressure. Strength gains occur in 6 weeks. So what is an example of a brief, repetitive, isometric exercise? 20 maximum contractions held 5 to 6 seconds and performed daily. I would say that's probably a quad set or a glute set. Yes? Yes? Okay. Resistance training. I cannot say that word. Chart. Okay. Light, moderate, and heavy repetitive loading. Outcome. So for light repetitive loading, we have muscular endurance. Percentage of 1 rep max is less than, no, not more than 70%, right? So light repetitive loading, outcome is muscular endurance, 70% of your 1 rep max. Repetition range, 12 to 20. Number of sets, 1 to 3. Rest between sets, 20 to 30 seconds. Okay, if you're going for hypertrophy and strength, which is moderate, relatively loaded, You would want 70 to 80% of your 1 rep max. You would do 8 to 12 repetitions, 1 to 6 sets, 30 to 120-second rest in between. If you're going for maximal strength, you would do 80 to 100% of your 1 rep max. That would be heavy loading. 1 rep range would be 1 to 8. And then number of sets would be 1 to 5. And you would take 2 to 5 minutes in between your sets. Yes. So muscular endurance, hypertrophy and strength, maximal strength. Percentage of your 1 rep max, 70% or less, 70 to 80%, 80 to 100%. So you need to calculate your 1 rep max in order to be able to determine what that weight is. Repetition range, muscular endurance, 12 to 20. Hypertrophy and strength, 8 to 12. Maximum strength, 1 to 8 rep range. What if you were wanting to do basically neuromuscular re-education? How many reps would you do then? Let's say right after a ACL and you're re-educating the quad. How many reps would you do? Probably more on the muscular endurance rep range, 20. Yeah, 20. This would not apply. Oops. The percentage of 1 rep max, I don't believe that would apply. Because this is resistance training chart for resistance. So it doesn't include neuromuscular re-education of a muscle. Okay, endurance training strategies to develop muscular endurance. Muscular endurance, the ability of an isolated muscle group to perform repeated contractions over time, is improved by performing low resistance exercise for many repetitions. Exercise and programs that increase strength also increase muscular endurance. Let me repeat that. Muscular programs that increase strength also increase muscular endurance. Muscular endurance programs are indicated after injuries to joints and soft tissues. Dynamic exercises at a high number of repetitions against light resistance are more comfortable and create less joint irritation than heavy resistance exercises. Early in the strength training program, high repetitions and low load exercises causes less muscle soreness and reduce the risk of muscle injury. Training strategies to develop cardiovascular endurance. Cardiovascular endurance, the ability to perform large muscle dynamic exercise such as walking, swimming, and biking for long periods of time. Overload principle, used to enhance physiological improvement and bring about a training change. Specific exercise overload must be applied. Training adaptation occurs by exercising at a level above normal. The appropriate overload for each person can be achieved by manipulating combinations of training frequency, intensity, and duration. Specificity principle. Adaptations in the metabolic and physiological systems, depending on the type of overload imposed. Specific exercise elicits specific adaptations, creating specific training effects. For example, Swim training will increase cardiovascular conditioning only when tested in swimming. There is no crossover for conditioning from swimming to running. Individual differences principle. Individual differences principle. Training benefits are optimized when programs are planned to meet the individual needs and capacities of the participants. Reversibility principle. Detraining occurs rapidly after only 2 weeks when a person stops exercising. Beneficial effects of exercise training are transient and reversible. Exercise and progressive activity regimens require monitoring of heart rate, blood pressure, and other signs and symptoms of exertional intolerance. See Chapter 3. FIT equation includes factors that affect training, frequency, intensity, time, and type. Intensity is interrelated with both duration, time, and frequency. Frequency is the number of exercise sessions per week. If training at a lower intensity, then more frequent exercise is indicated. If the intensity is constant, the benefit from 2 versus 4 or 3 versus 5 times per week is the same. For weight loss, 5 to 7 days per week increases the caloric expenditure more than 2 days per week. Less than 2 days per week does not produce adequate changes in aerobic capacity or body composition. Intensity overload is the primary way to improve cardiovascular endurance. Relative intensity for an individual is calculated as a percentage of the maximum functional function. Relative intensity for an individual is calculated as a percentage of the maximum function. Maximum oxygen consumption, VO2 max, or maximum heart rate. The VO2 max or heart rate max can be measured directly or indirectly based on different methods. Examples are a 3-minute step test, a 12-minute run, or a 1-mile walk test. Heart rate max can be estimated using 220 minus the age of the individual. Training level or targeted heart rate can be established at 70% of maximum to increase aerobic capacity. Provonen's formula is used to predict heart rate reserve or heart rate max minus the resting heart rate and correlates directly to VO2 max. Target heart rate. Heart rate max minus resting heart rate times percentage of desired training intensity plus resting heart rate. Target heart rate equals heart rate max minus resting heart rate times percentage of desired training intensity plus target plus resting heart rate. So let's see. Let's do some calculations. So let's say our target heart rate is, we don't know, target heart rate, okay, equals, let's say that our heart rate max is 180, okay, and we're going to subtract our resting heart rate, which is, let's say, 80. Times percentage, let's say we want What did it say up here? Training level or target heart rate can be established at 70% of maximum. So let's say we want 70% of desired training intensity plus resting heart rate, which is 80. So that would be your and I'm basically putting this in here so that when I go back to study this, I will see it. Okay, moving on. Rating of perceived exertion. I'm going to get a drink of my Crystal Light. Okay. Rating of perceived exertion can be used to evaluate training at sub-maximal levels. A cardiorespiratory training effect can be achieved at a rating of somewhat hard or hard, 13 to 16 on the original board scale of 6 to 19. An appropriate level of training to result in conversational exercise or talk test. Moderate exercise that is not too strenuous and can improve endurance. So to improve cardiovascular endurance, cardiorespiratory training effect, it needs to be between somewhat hard and hard, which is 13 to 16 on the original board scale of 6 to 19. Appropriate level of training should result in conversation exercise or talk tests. Moderate exercise that is not too strenuous and can improve endurance. Duration, time. Duration is increased when intensity is limited by initial fitness level. Limited, for example, by your initial fitness level. Improvements in aerobic capacity, therefore, depend on increasing exercise duration and frequency. For example, 3 to 5 minutes per day produces training effects in poorly conditioned individuals, whereas 20 to 30 minutes, 3 to 5 times per week, is optimal for conditioned people. Multiple sessions of short durations are also indicated when intensity is limited by environmental conditions, such as heat and humidity, or by medical conditions, such as intermittent claudication or congestive heart failure. Obese individuals should exercise at longer durations and lower intensities. At this exercise level, the person can speak without gasping and does not have a muscle ache or burn from lactic acid accumulation. Obesity increases the mechanical work of the heart and can lead to cardiac and left ventricular dysfunction. Type of exercise needed to increase cardiovascular endurance should involve large muscle groups activated in rhythmic aerobic nature. Specificity of training should be considered. See Chapter 3. Training strategies to develop pulmonary endurance. Pulmonary endurance is related to the ventilation of the lungs and oxygen consumption. Ventilation is the process of the air exchange in the lungs. The volume of air breathed each minute, or minute ventilation, is 6 liters. Minute ventilation, minute ventilation equals breathing rate times tidal volume. So minute ventilation is your respiratory rate and your tidal volume. In maximum exercise, increases in breathing rate and depth can produce ventilation as high as 20 liters per minute. Energy is produced aerobically as oxygen is supplied to exercising muscles. Oxygen consumption rises rapidly during the first minutes of exercise and then levels off as the aerobic metabolism supplies the energy required by the working muscles. Steady state. The more fit a person is, the more capable their respiratory system is of delivering oxygen to sustain aerobic energy production at increasingly higher levels of intensity. Obesity can impair pulmonary function because of the added effort to move the chest wall. In severe pulmonary disease, the cost of breathing can reach 40% of the total exercise oxygen consumption. This decreases the oxygen available to the exercising non-respiratory muscles and limits exercise capabilities. Obesity can significantly increase the level of impairments. Okay, I went and found some beautiful pictures on the internet. So, minute ventilation, the volume of gas exhaled per minute. So that, how you compute that number is the volume of gas exhaled each breath. So your tidal volume. Inhale, exhale. Volume of gas exhaled per breath. So inhale, exhale. That's your tidal volume. And then your breathing frequency is your respiratory rate. So how many breaths per minute? So you would take the volume of gas exhaled per breath times your respiratory rate per minute. I have this pretty picture, anything like that. I'm going to pause the video and refresh your memory on lung volumes. That would be good. So we've already read this slide, so let's move on. Exercise-induced asthma can occur when the normal initial bronchodilation is followed by bronchoconstriction. The reduction in airflow from airway obstruction affects the ability of the lungs to provide oxygen to exercising muscles. Exercise-induced asthma is an acute, reversible airway obstruction that develops 5 to 15 minutes after strenuous exercise when a person does not breathe through the nose, which warms and humidifies the air. When a person mouth breathes, the air is cold and dry, contributing to the bronchoconstriction. Lowering the intensity level and allowing the person to breathe through the nose will allow prolonged aerobic exercise to continue. The problem is rare in activities that require only short bursts of activity, such as baseball, but is more likely to occur in endurance activity, such as soccer. When exercising in humid versus dry environments, the exercise-induced asthmatic response is considerably reduced. Chapter 4. Aerobic training. Aerobic training, cardiovascular endurance training can result in higher fitness levels for healthy individuals. Slow the decrease in functional capacity in the elderly, and recondition those with illness or chronic disease. Positive effects of aerobic training on the cardiovascular and respiratory systems. Improve breathing volumes and increase VO2 max. Increase heart weight and volume. Cardiac hypertrophy is normal with long-term aerobic training. Increase total hemoglobin and oxygen delivery capacity. Decrease resting and submaximal exercise heart rates. Can be utilized to measure improvement from aerobic training. Increase cardiac output and stroke volume. Improve distribution of blood to working muscles, and enhance capacity of trained muscles to extract and use oxygen. Reduce resting blood pressure. Continuous training at a submaximal energy requirement can be prolonged for 20 to 60 minutes without exhausting the oxygen transport system. Work rate is increased progressively as training improvements are achieved. Overload can be accomplished by increasing the exercise duration. In healthy individuals, continuous training is the most effective way to improve endurance. Circuit training uses a series of exercise activities that are repeated several times. Several exercise modes can be utilized involving large and small muscle groups, both statically and dynamically. Circuit training improves endurance and strength by stressing the aerobic and anaerobic energy systems. Interval training includes an exercise period followed by a prescribed rest interval. It is perceived to be less demanding than continuous training and tends to improve strength and power more than endurance. A relief interval can be passive or active. Its duration ranges from a few seconds to several minutes. Active or work recovery involves doing the exercise at a reduced level. During the relief period, the portion of adenosine triphosphate, ATP, and oxygen used by the muscles during the work period is replenished by the aerobic system. The longer the work interval, the more the aerobic system is stressed. With appropriate spacing of work relief intervals, a significant amount of high-intensity work can be achieved. The total amount of work completed with interval training is greater than the amount of work accomplished with continuous training. Warm-up and cool-down periods. Each exercise session includes a 5 to 15 warm-up and a 5 to 15 minute cool-down period. The warm-up period prevents the heart and circulatory system from being suddenly taxed. It includes low-intensity cardiorespiratory activities and flexibility exercises. The cool-down period also consists of exercising at a lower intensity. It reduces abrupt physiological alterations that can occur with sudden cessation of strenuous exercise. For example, venous pulling in the lower extremities, which causes decreased venous return to the heart. Longer warm-up and cool-down periods may be needed for deconditioned or older individuals. Common errors associated with muscular, cardiovascular, and pulmonary endurance training. Lack of exercise tolerance testing, ETT, before the exercise prescription is determined could result in a training program set too high or too low for that individual. Starting out too high a level can overly stress the cardiorespiratory and muscular systems and potentially cause injuries. increasing intensity too fast can create a problem for the individual during endurance training. Exercising too intense a level can use the anaerobic energy system, not the aerobic system. This increases strength and power, not endurance. Insufficient warm-up or cool-down results in inadequate cardiorespiratory and muscular adaptation. There is inadequate time to prepare for or recover from higher intensity activity. Inconsistent training, frequency, duration, or intensity does not properly stress or overload the aerobic system to create training effects. Exercise at high altitude. At altitudes of 6,000 feet or higher, there can be a noticeable drop in performance of aerobic activities. The partial pressure of oxygen is reduced, resulting in poor oxygenation of hemoglobin. This hypoxia at altitude can result in immediate compensatory hyperventilation, stimulation of the baroreceptors, and increased heart rate. Reduction of CO2 from hyperventilation results in more alkaline body fluids. E is over here. Adjustments or acclimatization to higher altitude. Takes 2 weeks at 2,300 meters and an additional week for every additional 600 meters in altitude. There is a decrease in plasma volume, concentrating red blood cells, and an increase in total red blood cells and hemoglobin, improving oxygenation. Changes in local circulation may facilitate oxygen transport. Adjustments do not fully compensate for altitude. VO2 max is decreased 2% for every 300 meters above 1,500 meters. There is a drop in performance for endurance activities. Training at altitude does not provide any improvement in sea level performance. The air in mountainous regions tends to be cool and dry. Body fluids can be rapidly lost through evaporation and result in dehydration. Ensure adequate hydration for those exercising or engaged in sports at altitude. Men and women can adapt equally well to heat, even though the mechanism of thermoregulation differs slightly. The menstrual cycle is not a factor. Obesity is a major consideration when exercising in the heat. Exercise recommendations for individuals with obesity, see Chapter 6. Mobility and flexibility training. Flexibility refers to the ability to move a joint through an unrestricted, pain-free range of motion. The muscular tendinosus unit elongates as the body segment moves through the range of motion. Dynamic flexibility refers to the active range of motion of a joint and is dependent upon the amount of tissue resistance met during active movement. Passive flexibility is a degree at which a joint can be passively moved through the available range of motion and is dependent upon the extensibility of the muscle and connective tissue around the joint. Stretching. Stretching involves any therapeutic technique that lengthens, shortens soft tissue structures and increases range of motion. Type of stretching is determined by the type of force applied, the intensity of stretch and duration of stretch to contractile and non-contractile tissues. Manual passive stretching takes the structures beyond the free range of motion to elongate tissues beyond their resting length. The stretch force is applied for at least 15 to 30 seconds and repeated several times during a session. Manual stretching is considered a short duration stretch and is maintained statically for less time than mechanical stretching. Intensity and duration depend on patient tolerance and therapist strength and endurance. Low intensity manual stretch, applied as long as possible, is better tolerated and results in optimal improvement in tissue length with minimal risk of injury to any weakened tissue. Ballistic stretching is a high intensity, very short duration bouncing stretch. By contracting the opposite muscle group, the patient uses body weight and momentum to elongate the tight muscle. It is considered unsafe because of poor control and the potential of rupturing weakened tissues. It should not be performed after an injury or surgery. Ballistic stretch facilitates the stretch reflex, causing an increase in tension in the muscle that is being stretched. It is contraindicated in spastic muscles. Prolonged long-intensity mechanical stretching. An external force, 5 to 15 pounds to 10% of the body weight, is applied by positioning a patient with weighted pulley and traction systems. For example, to reduce knee flexion contractures in a patient who is bedridden may be maintained for 20 to 30 minutes or as long as several hours. A dynamic splint maintains the limb positioned at end range and is typically applied for 8 to 10 hours to increase range of motion. For example, reduced wrist and finger flexion contractures. A serial cast maintains the limb positioned at end range. A cast is typically, my goodness, stop it, please. The serial cast maintains the limb positioned at end range. The cast is typically applied for 5 to 7 days. Cast is then removed and a new cast reapplied with the limb positioned in the newly gained range. For example, to reduce gastrosoleus contractures. Low-intensity prolonged stretching has been shown to be more effective than manual passive stretching with long-standing flexion contractures. Active stretching occurs when voluntary, unassisted movement by the patient provides the stretch force to a joint. It requires strength and muscular contraction of the prime mover to actively stretch the antagonist muscle group. The force is controlled by the patient and is considered low intensity to tolerance. The risk of tissue injury is low. Duration is equal to passive manual stretching or about 15 to 30 seconds and is limited by prime mover muscular endurance. Facilitated stretching, active inhibition, refers to techniques in which the patient reflexively relaxes the muscle to be elongated prior to or during the stretching technique. For example, PNF, see Table 9.2. Indications for active inhibition techniques include limitations in range of motion caused by muscle tightness or muscle spasm. Techniques are not effective with connective tissue changes. Hold, relax is indicated for the patient with limited movement and pain. Contractile muscle. A muscle that is lengthened over a prolonged period will have an increase in the number of sarcomeres in series. The muscle will adjust its length over time. A muscle immobilized in a shortened position will have a decrease in the number of sarcomeres and an increase in connective tissue. The sarcomere adaptation is transient. A muscle allowed to resume its normal length will produce or absorb sarcomeres, lengthen or shorten. Neurophysiological properties of contractile tissue. The muscle spindle monitors the velocity and length changes in muscle. A quick stretch to a muscle stimulates the alpha motor neurons and facilitates muscle contraction via the monosynaptic stretch reflex. This can increase tension in the contracting muscle and provide reciprocal inhibition to the tight muscle. The GTO inhibits contraction of the muscle. When excessive tension develops, the GTO fires, inhibiting alpha motor neuron activity and decreasing tension in the muscle. Slow stretching, especially applied at the end range, causes the GTO to fire and inhibit the muscle, autogenic inhibition, allowing the muscle to lengthen, stretch protection reflex. So I think this is a slide that probably needs some more time. 27, so I'm going to go ahead and do this at the end and go over this from the end. Where we were. And here we are with the facilitated stretching techniques, hold, relax. A relaxation technique usually performed at the point of limited range of motion in the agonist pattern. An isometric contraction of range-limiting antagonist is performed against slowly increasing resistance, followed by voluntarily relaxation and passive movement by the therapist into a newly gained range of the agonist pattern. The muscle relaxes as a result of autogenic inhibition, possibly from GTO firing and decreasing muscular tension. Hold relax active contraction. Following hold relax technique, active contraction into the newly gained range of the agonist pattern is performed. Additional muscle relaxation is achieved through active contraction and reciprocal inhibition effects, a spindle response. Contract, relax, active contraction. A relaxation technique usually performed at a point of limited range of motion in the agonist pattern. Isotonic movement in rotation is performed followed by an isometric hold of the range-limiting muscles in the antagonist pattern against slowly increasing resistance, voluntary relaxation, and active movement into the new range of the agonist pattern. Utilizes effect of both autogenic inhibition and reciprocal inhibition. So here is another one that have more time. Okay, let's finish the reading and then we'll go back and do some more in-depth studying on those two. Non-contractile connective tissue, including ligaments, tendons, joint capsules, fascia, and skin, can affect joint flexibility and requires remodeling to increase length. Low magnitude loads over long periods increase the deformation of non-contractile tissue, allowing a gradual rearrangement of collagen bonds, remodeling. This type of stretch is better tolerated by the patient. 15 to 20 minutes of low-intensity sustained stretch repeated on 5 consecutive days can cause a change in the length of muscles and connective tissue. Intensive stretching is usually not done every day in order to allow time for healing. Without healing time, a breakdown of tissue will occur, as in overuse syndromes and stress fractures. With aging, collagen loses its elasticity and tissue blood supply is decreased, reducing healing capability. Stretching in older adults should be performed cautiously. Overstretch is a stretch well beyond the normal joint range of motion, resulting in hypermobility. If the supporting structures of a joint are insufficient and weak, they cannot hold a joint in a stable functional position during functional activities. This is known as stretch weakness. Contracture is an adaptive shortening of muscle or other soft tissues that cross a joint. Contracture results in decreased range of motion. Myostatic contracture, pertaining to muscle, involves a musculotendinosus unit that has adaptively shortened with loss of range of motion. Usually occurs without specific tissue pathology and in two joint muscles such as the hamstrings, rectus femoris, or gastrocnemius. Can typically be resolved in a short time with gentle stretching exercises and active inhibition techniques. Adhesions, an abnormal union of membranous tissue resulting from injury or inflammation, can occur if tissue is immobilized in a shortened position for extended periods of time, resulting in a loss of mobility. Scar tissue adhesions develop due to injury and the inflammatory response. Initially, new fibers develop in a disorganized pattern and will restrict motion unless remodeling along lines of stress. For example, the patient with burns. Irreversible contracture, a permanent loss of a soft tissue extensibility that cannot be released by non-surgical treatment, occurs when normal soft tissue is replaced by an excessive amount of non-extensible tissue, such as bone or fibrotic tissue. Relaxation of muscles. Local relaxation techniques can assist in the lengthening of contractile and non-contractile tissue. Heat increases the extensibility of the shortened tissue. Warm muscles relax and lengthen more easily, reducing the discomfort of stretching. Connective tissue stretches with less force and shorter duration. GTO sensitivity is increased, making it more likely to fire and inhibit muscle tension. Low-intensity active exercise performed prior to stretching will increase circulation to the soft tissue and warm the tissues to be stretched. Heat without stretching, has little or no effect on long-term improvement in muscle flexibility. The combination of heat and stretching produces greater long-term gains in tissue length than stretching alone. Massage increases local circulation to the muscle and reduces muscle spasm and stiffness. Biofeedback helps the patient reduce the amount of tension in a muscle and improves flexibility while decreasing pain. Increased level of feedback signals, auditory or visual, assist the patient in recognizing tense muscles. Common errors associated with mobility and flexibility training. Passively forcing a joint beyond its normal range of motion. Aggressively stretching a patient with a newly united fracture or osteoporosis can result in fracture. Using high-intensity, short-duration ballistic stretching produces procedures on muscles and connective tissue that have been immobilized over a long time or recovering from injury or surgery. Stretching muscles around joints without using strengthening exercises to develop an appropriate balance between flexibility and strength. Overstretching of weak muscles, especially postural muscles that support the body against gravity. So these are the two slides I want to do a little bit more with, but I'm going a little break. So I'm going to pause. Please hold. Okay, guys, this is where we ended here. And I copied and pasted a couple of slides to do more in-depth studying on. Active inhibition, facilitated stretching. You need to be quiet. Nobody's talking to you. Be quiet. Dial it down. She said she'll dial it down. Anyway, facilitated stretching. Active inhibition refers to techniques in which the patient reflexively relaxes the muscle to be elongated prior to and during the stretching technique. So indications for active inhibition techniques include limitations in range of motion caused by muscle tightness or muscle spasm. Techniques are not effective with connective tissue changes. So hold, relax, which is also on this table. Hold, relax, a relaxing technique usually performed at the point of limited range of motion in the agonist pattern. An isometric contraction of the range-limiting antagonist is performed against slowly increasing resistance, followed by voluntary relaxation and passive movement by the therapist, looking down into the newly gained range of motion. So, isometric contraction of the range-limiting antagonist. Performed against slowly increasing resistance, followed by voluntary relaxation and passive movement by a therapist into the newly gained range of the agonist pattern. The muscle relaxes as a result of autogenic inhibition, possibly from the GTO firing and decreasing muscular tension. So let's go here. Autogenic inhibition is accomplished via muscle contraction before a passive stretch of the same muscle. So you actively contract that muscle before it is passively stretched. So I found a cute little video here. Let's go ahead and look at this. PNF hold, relax, stretch.
Let's now address the hold, relax, PNF stretching technique. Before we start any sort of partner stretching, we should be setting up some appropriate communication terms with our client and between the trainer. We're going to set a 1 to 5 stretch scale where we want to make sure all of our stretches are lying between the 3 to 4 range. To start this technique, we're going to ask our client to raise their leg to put their hamstrings through a passive range of motion stretch of around about that 3 to 4 scale. Make sure you as a trainer are setting yourself up appropriately so you do not injure yourself. Let's put our client now through our passive range of motion stretch.
Oops.
How's that feeling there?
Yeah, that's good.
What sort of numbers are we at?
3.
Let's now address the hold, relax, PNF stretching technique. Before we start any sort of partner stretching, we should be setting up some appropriate communication terms with our client and between the trainer. We're going to set a 1 to 5 stretch scale where we want to make sure all of our stretches are lying between the 3 to 4 range. To start this technique, we're going to ask our client to raise their leg to put their hamstrings through a passive range of motion stretch of around about that 3 to 4 scale. Make sure you as a trainer are setting yourself up appropriately so you do not injure yourself. Let's put our client now through our passive range of motion stretch. How's that feeling there?
Yeah, that's good.
What sort of numbers are we at?
3.
Fantastic. We're going to hold this for approximately 10 seconds. 8, 9, 10. From here, we're going to ask our client to isometrically contract towards the trainer for 6 seconds. Off we go. How's that rating there? Do you feel it around about 3 or 4? Fantastic. 5, 6. We're going to ask our client to relax for a couple of seconds and then further move into a passive stretch of a rating of about 3 or 4. How's that feeling there?
Yep. 4.
Fantastic. We're going to hold this stretch for another 10 to 15 seconds. (14, 15) and relax. Once you have completed this particular technique once, ask your client to relax for a couple of seconds and then you can repeat it 2 to 3 times.
Hello, doctors. I am Dr. Donald Ozello of Championship Chiropractic in Las Vegas, Nevada. One type of PNF stretching is the hold, relax technique. We are going to be stretching the patient's hamstrings. The patient is laying supine. What we're going to do is passively raise the patient's leg into hip flexion, instruct the patient to inform you when they start to feel a mild, comfortable stretch. Got it right there. We're going to place the lower leg onto our shoulder. You want to place both hands on the anterior proximal thigh. And what we're going to do, we're going to instruct the patient to contract the hamstrings and push against us. And we are going to hold this position so it is an isometric contraction. Again, when we are doing hold release technique, it is a isometric contraction. The patient is going to take a deep breath, hold it, contract for 10 seconds. We're going to count 10 seconds. When that 10 seconds is up, we're going to ask the patient to exhale, and then we are going to increase the stretch. 5, 6, 7, 8, 9, 10. Breathe out, and then we slowly increase the stretch and hold this position. You can hold this position anywhere from 5 seconds to 120 seconds. And once that stretch is complete, we're just going to repeat. You ask the patient to take a deep breath in, hold it, and push against with 75 to 90% of strength. 6, 7, 8, 9, 10. Relax. And then we gradually increase the stretch. And then we're going to repeat. You want to repeat this 3 to 4 times when performing the hold, relax technique of PNF stretching for the hamstrings. Hello, doctors. I am Dr. Donald Lozello of Championship Chiropractic in Las Vegas, Nevada. One type of PNF stretching is called hold, relax, contract agonist. I'm going to be demonstrating with the patient's hamstring muscles. Patient is laying supine in a relaxed position. What we're going to do is passively bring the leg into hip flexion. Ask the patient to let you know when they feel a mild, comfortable stretch of the hamstring muscles. So we've achieved a mild, comfortable stretch. Going to place the shoulder underneath the posterior lower leg. You want to place both hands on the anterior proximal thigh. You're going to ask the patient to contract the hamstrings, and we're going to hold this position. So it's an isometric contraction. They're going to perform that for 10 seconds. They're going to take a deep breath in, hold it, perform the contraction, and then when they're done, going to breathe out. We increase the stretch, and while we are increasing the stretch, we ask them to contract the hip flexor muscle. So they are contracting the antagonist muscle of the muscle that we are stretching. So go ahead, take a deep breath in, hold it, push against me with 75 to 95% of your strength for 10 seconds. 3, 4, 5, 6, 7, 8, 9, 10. Relax. Okay, let me know when you feel a mild, comfortable stretch, and go ahead and contract the hip flexor muscles. Okay. And we're going to hold this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Relax. I want you to take a deep breath in, hold it, and push against me with 75 to 95% of strength. 3, 4, 5, 6, 7, 8, 9, 10. Breathe out and relax. We're going to immediately increase the stretch and ask the patient to contract the hip flexor muscles, which are the antagonist of the hamstrings. And we hold this for 10 to 15 seconds and then relax. You're going to perform 3 to 5 repetitions of hold, relax, contract, agonist. And then when those 3 to 5 repetitions are complete, then we gradually lower the leg back to the starting position. Chiropractic in Las Vegas, Nevada. One type of PNF stretching is called contract relax. Contract relax is when the muscle that is being stretched first performs an isotonic contraction. I'm going to be demonstrating on the hamstring muscles. The patient is laying supine. We're going to raise the patient's leg into hip flexion until they feel a mild, comfortable stretch. Go ahead and let me know, okay? Patient has achieved a mild, comfortable stretch. What we're going to do is we're going to ask the patient to take a deep breath in, hold it, push against us with 75 to 95% of their strength. As they are doing this, we are going to allow the leg to move in the direction of the muscle contraction. So it's an isotonic contraction. We're going to have them do that for 10 seconds. When 10 seconds is up, tell them to breathe out and relax, and then we are going to increase the stretch and repeat. So let's go ahead and start. Okay, let me know when you feel a mild, comfortable stretch. Okay, once you take a deep breath in, hold it and push against me with 75 to 95% of your strength. 5, 6, 7, 8, 9, 10. Breathe out and relax. We're going to slowly increase the stretch. Let me know when you feel a mild, comfortable stretch. Okay, then we're going to hold this stretch anywhere from 5 seconds to 120 seconds. Once that time frame is up, we're going to repeat. Ask the patient to take a deep breath in, hold it, and push against you with 75 to 95% of your strength. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Breathe out and relax. Once that 10 seconds is up, and we increase the stretch. Let me know when you feel a mild, comfortable stretch. And we're going to hold this stretch from 5 to 120 seconds, and we're going to repeat 3 to 5 repetitions when performing contract, relax technique of PNF. And then when we're done, we're going to slowly lower the leg back to the starting position.
Okay. The only thing I didn't really like about those videos is him telling the patient to hold their breath while they are contracting. So basically, what is that, the Vaselva maneuver? So anyway, let's see, let's go back here. So I added, so neurophysiological properties of contractile tissue. The muscle spindle monitors the velocity and length changes in the muscle. What is the muscle spindle? It's located in the muscle belly, lying parallel to the fibers. It causes a reflexive contraction, a stretch reflex in the muscle when the muscle senses a force. It simultaneously causes the relax, the reciprocal inhibition. A quick stretch to the muscle stimulates the alpha motor neurons and facilitates muscle contraction via the monosynaptic stretch reflex. This can increase tension in the contracting muscle and provide reciprocal inhibition to the tight muscle. So reciprocal inhibition is accomplished by contracting the muscle, opposing the muscle that is being passively stretched. So reciprocal inhibition, contracting the muscle, opposing the muscle that is being passively stretched. So if you're stretching the hamstrings, the muscle that opposes the hamstrings is the quadriceps, and one of the quadriceps is also a hip flexor. So squeezing the quads and flexing the hip would be the muscles that oppose the muscle that is being passively stretched, and that is reciprocal inhibition. So autogenic inhibition, which is accomplished by contracting the muscle opposing, Autogenic inhibition is accomplished via active contraction before a passive stretch of the same muscle. So autogenic inhibition is actively contracting the hamstrings before you passively stretch the hamstrings. So autogenic inhibition, actively contracting the hamstrings before a passive stretch of the hamstrings. Actively contracting the hamstrings before passively stretching the hamstrings. That's autogenic inhibition. Reciprocal inhibition, contracting the muscle opposing the muscle that is being passively stretched. So contracting the quadriceps, which is squeezing the quads, flexing the hip, because the rectus femoris is a hip flexor as well as a knee extensor. So by contracting the quads that oppose the muscle, which is the hamstrings, that is being stretched. Got it? Yes. So that's just talking more about reciprocal inhibition. When one muscle is contracted, the agonist is automatically inhibited. Contracting the muscle opposing the muscle that is being stretched. One muscle is contracted, the agonist is automatically inhibited. So when you're contracting the quadriceps, then the hamstrings will relax and it will help you stretch the hamstrings. Here's another picture of reciprocal inhibition. Contract, activate reciprocal muscle group to lengthen, release the target muscle group. So you're actively contracting the quads so you can lengthen and release the hamstrings. And then autogenic inhibition. Oops, no, I don't want to do that. Let's go ahead and copy this and bring it. Okay, so autogenic inhibition. Active contraction, active contraction before passive stretch of the same muscle. So you're actively contracting the hamstrings 3 to 5 seconds before you passively stretch the same muscle. That's autogenic inhibition. And here's the 3 again. Hold, relax active contraction, and contract, relax active contraction. And then I threw in a little spinal cord thing from Neuroanatomy and Clinical Context book. And then, all right, well, this video got really long, so we're going to stop it here at almost 2 hours. And going to take a little break, go eat lunch, and come back and do the next video on traumatic brain injury.